Imagine an organ, maybe the size of your fist, that just keeps going. Over 100,000 beats a day, every single day, for your whole life. It's kind of amazing, right? How does something so vital, so complex, I mean, it's this continuous rhythmic miracle. How does it keep pumping without, ever stopping? Today, we're taking a deep dive into exactly that question. Our guide, the foundational text, Boron and Boulpaep's Medical Physiology, specifically Chapter 22, The Heart is a Pump. Our mission here is to unpack all the dense mechanics of the cardiac cycle, make it clear, maybe even engaging, and definitely clinically relevant for you, whether you're like cramming for an exam or just really curious about how your body works. We're going to build it up step by step, big picture down to the tiny details, so you really get not just what's happening, but how, and crucially, why it matters. Okay, let's get into this.
Right. So at its most basic, the cardiac cycle. It's just that repeating sequence, all the mechanical stuff, the electrical stuff that happens with every single heartbeat. Think of it like one full turn of the heart's engine and how long it takes. Well, that just depends on your heart rate. It's the reciprocal. So say 75 beats per minute. That whole cycle is about 0.8 seconds long. Quick.
Wow, 0.8 seconds. And it's such a sophisticated machine. I like thinking of it as a two-stroke pump. Is that fair?
That's
It's constantly switching between filling up, taking blood in, and then emptying it, pushing blood out, phase 1, phase 2. And the whole thing is perfectly timed by that internal pacemaker, the sinoatrial node, right?
That's a really good way to visualize it, yeah. A two-stroke pump. And it has 4 chambers doing the work. You've got the atria, the 2 smaller upper chambers. They mostly act like reservoirs, waiting rooms for blood. The right atrium gets blood from the body, the left from the lungs. Now, they do contract. People call it the atrial kick. But honestly, at rest, it's kind of a small bonus. Adds a bit to ventricular filling, sure, but it's not the main event. The real power comes from the ventricles, the 2 bigger lower chambers. They do the heavy lifting.
Got it. Atria are reservoirs, ventricles are the power pumps. And to make sure blood only goes one way, the valves, super important. So on the way in, between atria and ventricles, you have the AV valves, that's atrioventricular. Tricuspid on the right, 3 flaps, 3 cusps, and mitral on the left. That's the one with 2 cusps, looks like a bishop's hat, a mitre. Then on the way out, you've got the semilunar valves, pulmonary valve from the right ventricle to the lungs, and the big one, the aortic valve from the left ventricle to the rest of the body. Both have 3 cusps too.
And what's really elegant, I think, is how they work. They're completely passive. No muscles pulling them open or shut. It's just physics. Pressure. They open when the pressure before them is higher than the pressure after them. Simple. And they snap shut the moment the pressure after them gets higher. Prevents any backflow. Beautifully simple design.
And that simple passive action, it gives us, incredible clues about heart health. When those valves snap shut, that's what makes the lub-dub heart sounds we listen for. That's where clinicians become detectives, right? If a valve is leaky, blood flows backward, that's regurgitation. Or if it's narrowed, stiff, restricting flow, that's stenosis.
Exactly.
And both of those problems can create extra sounds like whooshing noises, murmurs. It's like listening to an orchestra, isn't it? A healthy heart has that clear beat, but a murmur tells you something's maybe a bit off, a potential issue.
Great analogy. So if we look at it from the ventricle's point of view, the main pump, we can break that 0.8-second cycle into 4 key phases, defined by those valve positions. First up, the inflow phase. Inlet valve is open, outlet valve is closed. The ventricle is just filling up with blood. Second, isovolumetric contraction. Now both valves are closed. Isovolumetric means same volume. The ventricle starts squeezing, but the volume can't change yet, so pressure shoots up fast. Third, the outflow phase. The pressure got high enough to pop open the outlet valve. So outlet's open, inlet's closed, blood is forcefully ejected. And fourth, isovolumetric relaxation. Both valves slam shut again. No blood flow in or out. The ventricle muscle relaxes, and the pressure inside plummets. Back to the start.
Okay, 4 phases. Inflow, isovolumetric contraction, outflow, isovolumetric relaxation. And we group those, right? Systole is the contraction part.
Yeah.
Phases 2 and 3, when the ventricle is squeezing and pushing blood out.
Correct.
And diastole is relaxation and filling. Phases 4 and 1.
That's it.
And you mentioned something interesting. As heart rate goes up, diastole shortens more than systole.
Yes, that's a critical point. Diastole take the bigger hit. Less time for the heart to fill, which has implications, especially during heavy exercise or certain conditions. Now, an important detail, the volume changes in the left and right ventricles. They're identical, same amount of blood pumped, but the pressures are totally different. The right side is a low-pressure system, just pumping to the lungs nearby. The left side, high pressure, pumping to the whole body. So to really understand the dynamics, let's focus on the left ventricle. Let's trace the pressure and volume changes through those 4 phases. Try to picture it like a graph in your head.
Okay, let's do it. Mental graph time. We start Where? Middle filling.
Yeah, let's start mid-phase 1 during diastasis. Mitral valves open, blood's flowing in from the left atrium, but it's kind of slowing down. Passive filling. You'd see left atrial pressure and left ventricular pressure slowly creeping up, almost together. Pretty low pressure still.
And right at the end of this slow phase, that's when the P wave happens on the ECG. Atrial signal.
Exactly. The P wave signals atrial excitation, which leads right into
Atrial contraction, the atrial kick.
right. The atria give that final little squeeze, pushing a bit more blood into the ventricle just before it contracts.
You said it's not huge at rest, less than 20%.
Correct. Less than 20% of the stroke volume at rest. But during really heavy exercise, when filling time is short, that kick can become much more important, maybe up to 40%.
So, clinically, how vital is that kick? What about something like AFib, atrial fibrillation? The atria are just quivering then, right? No real kick.
That's a great question. In atrial fibrillation, you lose that coordinated atrial contraction completely. For a healthy person just sitting around, they might not even notice. The ventricles usually compensate pretty well.
But if someone's heart is already struggling, like heart disease or hypertension.
Then losing that kick can be the straw that breaks the camel's back. It can push them into congestive heart failure, sometimes even shock. The body really struggles to compensate that.
Okay, so after the atrial kick, we see the QRS complex on the ECG, ventricular signal, and that triggers
Isovolumetric contraction.
Yep.
Phase 2. The ventricles start to squeeze.
and the pressure inside the left ventricle quickly goes above the left atrial pressure.
Instantly. And snap goes the mitral valve. Closed.
So now mitral valve is closed, aortic valve isn't open yet, both closed.
Right. Isovolumetric. Volume stays the same, but the ventricle is contracting hard. Pressure climbs. Steeply.
Right.
Dramatically. It keeps climbing until bang, it finally overcomes the pressure out in the aorta, and that forces the aortic valve open.
Leading us to phase 3, ejection or outflow. Aortic valves open, blood shoots out.
Yep. Initially, it's rapid ejection, a powerful surge. Ventricular pressure keeps rising for a bit. Aortic pressure falls right behind it. Ventricular volume drops like a stone.
And then it slows down a bit.
Right. Then you get decreased ejection. The rate slows. Ventricular and aortic pressures both start to fall now. On average, maybe 70 millivels gets ejected. That's the stroke volume. But importantly, there's still blood left behind. About 50 millivels or so, the end systolic volume. The ventricle doesn't empty completely.
Okay. Ejection done. What's next?
Isovolumetric relaxation. Phase 4. Blood flow in the aorta actually reverses for a split second, just enough to slam the aortic valve shut.
And that closure causes that little blip on the pressure tracing, the dicrotic notch.
That's it, the dicrotic notch or incisura. It's the signature of the aortic valve closing.
So now aortic valve closed, mitral valve still closed, both closed again.
Correct. And the ventricle muscle is relaxing. So pressure inside falls sharply, very rapidly.
It keeps falling until
Until it drops below the pressure in the left atrium, which has been filling up again.
And that opens the mitral valve.
Bingo. Mitral valve opens, and we enter the rapid ventricular filling period. Blood rushes in from the atrium. Ventricular volume shoots up quickly.
Which then slows down into diastasis.
And the whole cycle starts over again. Beautiful, isn't it?
It really is. Okay, so we've tracked pressure and volume, but you said the cycle shows up elsewhere too, like the ECG we mentioned.
Absolutely. The ECG is the electrical story.
P wave.
Atrial depolarization. QRS complex.
Yeah.
Ventricular depolarization, T wave, ventricular repolarization. They directly drive the mechanics we just discussed.
And the heart sounds, the lub-dub. Let's go back to those. S1 is the lub.
Yes, S1. It's mainly the sound, or rather the vibrations, from the AV valves, mitral and tricuspid closing, plus the vibration of the ventricular walls around them. It's usually a bit longer, lower pitched, maybe louder than S2.
And S2, the dub.
That's the closure of the semilunar valves, aortic and pulmonary. Again, it's the vibrations in the big arteries, the blood columns, right after those valves shut. And here's a cool detail about S2. Sometimes it sounds split, like a lub-de-dub.
Ah, the physiological splitting.
Exactly. It happens because the aortic valve normally closes just a tiny bit before the pulmonary valve, maybe just 20 milliseconds or so.
Why?
Higher pressure on the left side closes the aortic valve faster.
Yeah.
But this difference gets wider, more noticeable, when you breathe in.
Inspiration makes the split wider. How?
Breathing in decreases pressure in your chest, which pulls more blood back to the right side of the heart. More filling means the right ventricle takes slightly longer to eject its blood, so the pulmonary valve closes later. Makes the split easier to hear.
Fascinating. And there are other sounds clinicians listen for too, right? Pathological ones?
Definitely. You might hear an opening snap if the mitral valve is stiff, stenotic.
And S3 and S4 gallops.
Right. And S3 is heard in early diastole during rapid filling. It can be normal in kids or athletes, but in older adults it often means the ventricle is overfilled or stiff, a ventricular gallop.
Hmm.
And S4 happens just before S1 during atrial contraction. It's usually pathological. Means the atrium is contracting really forcefully against a stiff, non-compliant ventricle, an atrial gallop.
So many clues just from listening. It really is like a symphony or maybe Morse code from the heart.
It is. Now let's think about blood flow and pressure waves out in the arteries and veins. In the aorta, during that rapid ejection phase, flow velocity gets really high. So high it can actually become turbulent, not smooth laminar flow.
And as those pressure waves travel down the arteries, they change shape.
They do. They tend to get peakier, steeper upstroke, narrower peak. And weirdly, the pulse pressure, the difference between systolic and diastolic, can actually increase a bit as you move further away from the heart, even though the average pressure is dropping due to resistance.
Okay, that seems counterintuitive. How does the body handle the heart's jerky pulsatile output? It's not like flow stops between beats, right?
Perfect lead into the Windkessel model.
Yeah.
Brilliant concept. Imagine trying to push water through a rigid pipe versus a Strecky-compliant rubber hose.
Okay.
With the rigid pipe, flow stops the instant you stop pushing. With the rubber hose, it bulges, stores some energy, and keeps pushing water out even after you stop your main push.
So the aorta and big arteries are like the rubber hose?
Exactly. Their elasticity acts like a wind chamber. That's what Windkessel means. It absorbs the pressure surge during systole and then recoils during diastole, pushing blood forward.
Smoothing out the flow.
Precisely. It converts the heart's intermittent pumping into a much more continuous flow in the smaller arteries and arterioles. Massively improves efficiency. And this damping effect is so good that by the time blood gets down to the tiny capillaries, the pulsations are normally gone. Just smooth, continuous flow, which is perfect for exchanging oxygen and nutrients.
Okay, so that's arteries. What about venous pressure waves? Are they just echoes from the arteries?
Good question. No, they're not. Arterial pulses are damped out in the capillaries. Venous waves near the heart are generated differently. Three main things contribute. One, the cardiac cycle itself. The heartbeat actually sends little pressure waves backward into the big veins near the heart, like the jugular vein in your neck. You get these characteristic A, C, and V waves that correspond to atrial contraction, ventricular bulging, and venous filling.
Okay, what else?
Two, the respiratory cycle. When you breathe in, the diaphragm goes down, pressure in your chest drops. This negative pressure literally sucks blood into the big veins in your chest, from your head and arms.
But it affects the legs differently.
Yeah, because inhaling increases pressure in your abdomen, which can slightly slow down blood return from your legs. Breathing out reverses this.
And the third mechanism?
Three, the skeletal muscle pump, especially in your legs. When you walk, your calf muscles squeeze the deep veins. And because veins have one-way valves, this pushes blood upward towards the heart. It's super effective, significantly lowers venous pressure in your feet when you're active.
Right, the old don't lock your knees when standing advice helps the muscle pump work.
Okay, so we've got the big picture flow. Let's zoom back into the ventricles themselves. How do they actually do the pumping? Different styles for left and right.
Very different styles, tailored to their jobs. The right ventricle pumps against low resistance into the pulmonary artery. It works more like a bellows.
Like fanning a fire.
Kind of, yeah. Its large free wall moves towards the septum, sort of hinged. A small movement ejects a large volume. It's built for volume, not high pressure. It also gets a little help from the left ventricle squeezing the septum.
And the left ventricle, pumping to the whole body. That needs high pressure. So it contracts differently. More like squeezing a tube of toothpaste from the bottom up. It constricts circumferentially, and its long axis shortens significantly. It's built for power and pressure.
And are they perfectly in sync, left and right sides?
Close, but not quite. There are subtle but important timing differences.
Like what?
Well, the right atrium contracts slightly before the left because the SA node pacemaker is in the right atrium.
Okay, makes sense.
Then the left ventricle actually starts contracting a fraction earlier than the right. But paradoxically, the aortic valve closes before the pulmonary valve.
Ah, that's the S2 split again, because the left side pressure drops faster.
Exactly. And the right ventricle finishes its isovolumetric relaxation faster too, so it starts filling slightly before the left.
Yeah.
Tiny delays, but they matter for overall function and those heart sounds.
Okay, so how do we measure how well these ventricles are actually performing? What are the key metrics?
The basics are stroke volume, SV, and ejection fraction.
EF.
Stroke volume is simply how much blood gets pumped out with each beat. You measure the volume in the ventricle when it's fullest, that's end diastolic volume, or EDV. Then measure what's left after it ejects end systolic volume, or ESV. SV is just EDV minus ESV, so maybe 120 millimole minus 50 millil equals 70 millil stroke volume.
And ejection fraction, EF.
EF just puts SV in perspective. It's the stroke volume divided by the starting volume, the EDV. So 70 divided by 120 is, what, a 0.58 or 58%?
And healthy is usually above 55% or so.
Generally, yes. Below that can indicate weakened heart function. We measure these using things like echocardiography, ultrasound of the heart, or sometimes with catheters like a Swan-Ganz catheter for right heart pressures.
Okay, stroke volume, ejection fraction. Is there a way to visualize the work the heart is doing with each beat?
There is a really elegant tool called the pressure volume, PV loop. Instead of plotting pressure or volume against time, you plot pressure directly against volume throughout the entire cardiac cycle.
What does that look like?
You get this roughly rectangular loop that runs counterclockwise. Each side of the rectangle represents one of the 4 phases we talked about.
So filling is a line going rightwards at low pressure.
Yep. Isovolumetric contraction is a vertical line going straight up as pressure rises. Ejection is the top line moving left as volume decreases. And isovolumetric relaxation is a vertical line dropping straight down.
And the significance of this loop.
The area inside that loop represents the net external work done by the ventricle on the blood during that beat. The bigger the loop area, the more work the heart is performing.
Okay, that makes sense. The area is work. But here's something that seems surprising. That pumping work, it's actually only a tiny fraction of the heart's total energy use, like 3 to 10%.
That's absolutely right. It's a bit counterintuitive. The vast majority of the heart's energy, its oxygen consumption, goes into something called tension heat.
Tension heat, what's that?
It's the energy cost of just maintaining tension in the ventricular wall, especially during that isovolumetric contraction phase and ejection. Think about holding a heavy weight. You're not doing mechanical work by moving it, but your muscles are burning energy just to hold it there, generating heat. Same idea in the heart wall.
Ah, I see. So just being tense costs energy, even if you're not moving much blood yet.
Exactly. And the amount of tension heat depends on the wall tension itself related to pressure and how long the heart spends in systole, maintaining that tension.
So clinically, for someone with, say, coronary artery disease where oxygen supply is limited.
You want to minimize that tension heat.
Yeah.
Keep blood pressure low, reducing wall tension. Keep heart rate lower, reducing the time spent in systole.
And if you need to increase cardiac output,
The most energy-efficient way is usually to increase stroke volume, rather than cranking up the heart rate. Less wasted energy on tension heat per liter of blood pumped.
okay, fascinating stuff. Now let's get even smaller. Down to the individual heart muscle cells, the myocytes. How do they actually contract and relax? That's excitation-contraction coupling, right?
Precisely, EC coupling. It starts with that electrical action potential arriving at the myocyte. This opens special calcium channels, L-type channels, and a little puff of calcium ions enters the cell from outside.
The trigger calcium.
Yep, that's the trigger. It's not enough calcium to cause contraction itself, but it's critical because it binds to receptors, ryanodine receptors, RYR2, on the sarcoplasmic reticulum, the cell's internal calcium store,
And that triggers.
and much, much larger release of calcium from the SR into the cell cytoplasm. This is called calcium-induced calcium release, CICR. Get these calcium sparks.
So small trigger, big release.
Massive amplification. This big wave of calcium then binds to troponin C, a protein on the thin filaments. That binding moves another protein, tropomyosin, out of the way, allowing the myosin heads on the thick filaments to bind to actin and start the cross-bridge cycling. That's muscle contraction.
Okay, so calcium floods in, binds troponin, muscles contract. How does it relax? Gotta get rid of that calcium, right?
Absolutely. Relaxation is an active process too. As the action potential fades, the trigger calcium influx stops. Then the cell has to actively clear that calcium from the cytoplasm. 3 main ways. First, a pump, called a circuit 2A pump, uses energy, ATP, to pump calcium back into the SR store. Second, another transporter, the Naki exchanger, NCX1, pumps calcium out of the cell entirely. And third, calcium simply unbinds from troponin C as the concentration drops.
And there's a regulator for that circuit pump, phospholamban.
Ah, yes, phospholamban, PLN, very important. Think of it as a brake on the circuit pump. When PLN is not phosphorylated, it inhibits circa, slowing down calcium reuptake and relaxation.
Well, if you phosphorylate PLN, like with adrenaline during exercise.
Then the brake comes off. Phosphorylated PLN stops inhibiting circa. The pump works faster, sucks calcium back into the SR more quickly, and the muscle relaxes faster, allows the heart to keep up at high rates.
Cool. What about how much force the muscle generates? Is it like skeletal muscle where stretching it makes it stronger up to a point?
Yeah.
The length-tension relationship?
Yes, but with some key differences in cardiac muscle. First, cardiac muscle is stiffer passively, even at short lengths. This is partly due to a springy protein called titin. Second, the active tension, the force it generates when stimulated, increases much more steeply with length compared to skeletal muscle, up to an optimal length around 2.4 micrometers.
Why is it so sensitive to stretch?
It's not just better overlap of actin and myosin. Stretching cardiac muscle also seems to increase the sensitivity of troponin C to calcium, and it might even activate stretch-activated calcium channels, letting more trigger calcium in. So stretch itself boosts activation.
And that steep length-tension relationship is the basis for one of the most fundamental laws of the heart, Starling's law.
Exactly. Starling's law of the heart. Formally, it says something like, the mechanical energy set free is a function of the length of the fiber.
Okay, translate, please.
Much simpler. More in, more out. The more you stretch the heart muscle fibers at the end of diastole, meaning, the more the ventricle fills with blood, the more forcefully it will contract during the next systole, and the more blood it will eject.
So preload determines stroke volume, basically.
To a large extent, yes. It's the heart's intrinsic way of matching output to venous return. If more blood comes back, the heart automatically pumps harder.
And sympathetic stimulation, like adrenaline, that makes it pump even harder for the same amount of filling.
Correct. Sympathetic stimulation increases contractility, shifting that whole Starling curve upward and to the left on a graph. More pump power at any given preload.
Okay, let's nail down those terms again. Preload is.
Preload is the stretch on the muscle just before contraction. Clinically, we often use end diastolic volume, EDV, or end diastolic pressure as an index of preload. How full is the tank?
And afterload.
Afterload is the load or force the ventricle has to pump against to eject blood. Think of it as the resistance the heart sees. Arterial blood pressure is the main component and a good index of afterload.
So high blood pressure means high afterload.
Yep, and increased afterload makes it harder for the heart to eject blood, so stroke volume tends to decrease if afterload goes up, assuming other things stay equal.
Got it. Preload is stretch. Afterload is resistance. Now, you also mentioned heart rate affecting tension, the positive staircase.
Right, the Bowditch effect or positive staircase phenomena. As heart rate increases, myocardial tension or force development tends to increase with each beat, up to a point.
Why does that happen?
It's mainly due to calcium handling. At higher heart rates, there's less time between beats for the circuit pump and knock-can exchanger to fully clear calcium. So more calcium gets stored in the SR, and more gets released with the next beat, leading to a stronger contraction. The heart literally warms up, in a way.
So many factors influence performance. Preload, afterload, heart rate. How do we talk about the heart's intrinsic strength separate from those loading conditions? That's contractility.
Exactly. Contractility, or anotropy, refers to the inherent pumping capability of the heart muscle, independent of preload and afterload.
How do you measure that?
It's tricky to measure directly in a patient. One common way, often seen in research or estimated clinically, is using the end-systolic pressure-volume relation, ESPVR. Remember, like PV loop. You look at the point where systole ends, end systolic pressure and volume. If you do this at several different preloads or afterloads, the line connecting those end systolic points gives you the ESPVR.
And a steeper line means?
Steeper slope means greater contractility. The ventricle can generate more pressure for a given end systolic volume, indicating it's pumping more forcefully.
So drugs can change this slope.
Absolutely. Positive inotropic agents, things like adrenaline, noradrenaline, or drugs like digoxin, increase contractility, steepen the slope. They usually work by increasing intracellular calcium availability. Negative inotropic agents like beta blockers or calcium channel blockers decrease contractility, making the slope shallower.
This is all incredibly complex, but also beautifully interconnected, which brings us, I think, to a really important clinical spotlight: cardiac hypertrophy and heart failure. How does the heart adapt when things go wrong long-term?
The heart is remarkably adaptive initially. It responds to chronic stress by remodeling, by hypertrophy and growing bigger. But how it grows depends on the stress. If you have chronic volume overload, too much preload, maybe from a leaky valve or an AV shunt, the heart undergoes eccentric hypertrophy.
Yeah.
The chambers dilate, the cells get longer, more than wider, think bigger, baggier heart.
And if the problem is chronic pressure overload, like years of high blood pressure,
Then you get concentric hypertrophy. The ventricle wall gets really thick, the shells get wider, it's trying to generate more force to overcome that high afterload. Think thick muscular walls, maybe a smaller chamber inside.
but this hypertrophy, it's good at first, but it can't keep up forever, right? That leads to heart failure.
Exactly. Hypertrophy is initially compensatory. It keeps cardiac output normal for a while. But eventually, the hypertrophied heart often becomes less efficient, stiffer, and requires more oxygen. It can outgrow its blood supply. This maladaptive phase leads to heart failure.
And what's going wrong at the cellular level in heart failure?
It's complex and varies, but common themes emerge. Often, there's dysregulation of calcium handling. Maybe the coupling between the L-type channels and the SR release channels, RYR2, gets messed up. Or the RYR2 channels themselves become leaky, perhaps because a stabilizing protein called calstavin-2 is depleted. This can lead to calcium leaking out of the SR during diastole.
Which would impair relaxation and maybe cause arrhythmias?
Precisely. Chronically elevated diastolic calcium is bad news. Circa pump function might also decline. You can also see changes in the contractile proteins themselves. For instance, a shift from the faster alpha-myosin heavy chain isoform to the slower but perhaps more energy-efficient beta-myosin heavy chain.
And all these cellular changes manifest as the symptoms we see. Breathlessness, swollen ankles.
Yes. The failing left heart can't pump blood forward effectively, so it backs up into the lungs, causing congestion and shortness of breath. The failing right heart causes backup into the systemic veins, leading to swollen legs and ankles, enlarged liver, etc.
Wow, when you step back and look at all of it, from the calcium sparks in a single cell to the pressure waves in the aorta, the valve clicks, it's just staggering how remarkable the heart is. This incredibly sophisticated, self-regulating pump, amazing adaptability, but also, yeah, vulnerable to certain stresses. It's just a constant biological marvel inside us.
It truly is. And understanding these, intricate physiological mechanisms, it isn't just academic. It's absolutely the foundation for diagnosing problems, understanding the pathology, figuring out how treatments actually work in the real world. Every pressure reading, every murmur, every change on an ECG, it tells a story about health and disease. It's about learning to read that story.
Well, you've just navigated a really deep, complex dive into the heart's pumping action. I know this stuff can feel dense, maybe overwhelming at times, but breaking it down like this, piece by piece, you absolutely can get it. Remember, you're part of the deep dive family here, and you are definitely capable of mastering these vital concepts. So maybe as you go about your day to day, just take a second. Think about how incredibly finely tuned these mechanics are inside you. A valve closing milliseconds before another tells a whole story. What other hidden symphonies, what intricate processes are playing out inside us right now that we barely ever notice? Something to think about.